Okay. Hello, everybody. Welcome to episode, what is this, like 5 now? Yeah, and this might be the last episode for a little while. This is technically like our season finale, I guess. But we are all done with our English project now, the podcast, but we wanted to thank y'all for listening this entire time. We got such good feedback, and we enjoyed having all of y'all listen every single week and getting all your comments. It's been really amazing. And I wanted to end this podcast off with my own episode because I haven't hosted yet this entire podcast. So my episode will be on medical anthropology, and then let me reinstate what medical anthropology is and why I think it's so important to study and why I study it. So medical anthropology is looking how health and medicine is perceived by different cultures and how they have different health systems and different explanatory models for different illnesses, and also how health is not just biological processes in a patient. We are trying to reinstate patient in the term patient care because medicine has been so desensitized to like all patient emotions and well-being, etc., including like their spiritual, religious, emotional, mental well-beings. So medical anthropology just takes a look on how cultural, societal, political, environmental, economic factors can affect someone's illness. And yeah, and I didn't learn about it until I got into college. So I think it's a really important issue to discuss because all of our health is affected by things that we can't control, which is the whole gist of the podcast. So yes, and that perfectly leads into the interview portion. So we're just gonna play it for y'all right now, and we'll see y'all after for the discussion portion. Hello, everybody. Welcome to the interview portion. I will be interviewing myself this week, which is kind of funny, but it's because I couldn't find a guest. But I am the guest because I am an expert in all things medical anthropology, medical racism, because it is essentially all I think about, all I want to research, all I want to study, because it is so fascinating to learn how all of these systemic issues impact someone's health. So we're just going to dive right into it, and I can't wait to share the 4 topics I have for y'all. We're going to be covering critical medical anthropology as a subsection of anthropology and a field of study. And then afterwards, we're going to be transitioning into what medical racism is, and I'll be giving you some examples of medical racism throughout American history. And then we're going to be transitioning into how racism affects patients. And then our last portion will be how racism affects doctors. So, really, really excited. So, let me get started. Yes. So, medical anthropology, I learned about this concept from my professor, um, Julia Sloan. She is phenomenal. She teaches psychological anthropology at UCSD and one of my favorite professors that I have ever met. Genuinely, like if you can take a class, please take a class with her. She is so good at explaining how systemic issues affect every single aspect of healthcare. And critical medical anthropology focuses on how structures and systems shape the encounters of patients with their healthcare providers. And it was formed in the 1980s, and it introduced this concept of syndemics. And I'll get more into that later, but it essentially is like the interaction of diseases with social, political, economic factors. Yeah. So there are 4 main terms under the umbrella of critical medical anthropology. So the first term is structural competence. Structural competence is essentially healthcare providers understanding expectations, resources, and constraints of their patients and communities. And the second term we learned was structural vulnerability. Structural vulnerability is very important because it considers how social, economic, and political hierarchies produce and pattern poor health for individuals and populations. So, structural vulnerability essentially emphasizes how institutions and practices can contribute to medical risk and poor health outcomes for a patient. And there is structural violence. So, structural violence is symbols, institutions, and practices that allow one group to dominate another group, such as the white patriarchy in America today and how they dominate every single group. in terms of policy, resources, economics, etc., etc. Um, Structural violence is, to sum it up, institutions and practices that selectively limit access to resources and create inequity within society. And syndemics, the main star of critical medical anthropology, is essentially multiple health problems interacting under the conditions of social, political, and economic vulnerabilities. So, what I wanted to really bring y'all into this framework of diseases and health conditions that are influenced by social and political and economic factors, like biological processes are now being drastically influenced by things out of that are in someone's environment or out of someone's control, which is what I really wanted to emphasize in this podcast episode. Yeah. So we're going to be moving on to our next topic, which is medical racism. So medical racism, I really just wanted to define it for all of y'all. So medical racism produces discrepancies in the treatment of healthcare workers and patients based on their skin color and ethnicity. This could be through false medical myths about certain racial groups, misrepresentation in medical education books, and implicit biases towards certain racial groups over others, and etc. Medical racism has caused huge medical repercussions for patients, and modern medicine itself in America was founded on racism because a lot of the modern procedures and studies were done on black and brown bodies, and several surgeries that are still in use today were done at the expense of black and brown patients and their well-being, and also their loved ones' well-beings and their future generations, to be honest. um America's really unique. That's what we learned about in my medical anthropology classes. America's has a very distinct history of racializations where the health outcomes of patients in America is significantly affected by the race. So let me get into it. Let me get into the history of it so I can show you examples. In the South, the Mississippi appendectomy became extremely popular to sterilize poor Black women from the 1920s all the way to the 1980s. The 1980s, mind you, this is literally less than 50 years ago. Um, and in this procedure, doctors would perform non consensual hysterectomies on Black women. Black women were even brought into teaching hospitals for residents to practice hysterectomies on against their own will. Imagine medical residents practicing hysterectomies on Black women unconsensually. And this was a practice for 60 years. Um, the forced sterilization of Black women reached a peak number of over 800,000 Black women being sterilized under government law. And this law made it forced sterilization legal for Black women because it deemed that sterilization was acceptable for anyone that was deemed too primitive to have children. And as we know, what they deem primitive is essentially all minority groups. And this leads into my next thought. So, this law also made it legal to force sterilization onto Native Americans and Puerto Ricans throughout the 1960s and 70s. And this caused mass sterilization of indigenous women as well. The Indian Health Service, which is, I don't even know why they would call it a health service. They actually impeded their health, but the Indian Health Service performed so many forced hysterectomies in the 60s and 70s that 1 out of 4 indigenous women were sterilized. And as you can see, this probably ended generations of lineages and decreased the growth of these minority groups exponentially, which is what these white, um, white, rich, patriarchal societal systems wanted. Yeah. And another experiment I wanted to bring up was the Tuskegee experiment. And the Tuskegee experiment was an extremely awful medical experiment done to over 600 Black men in Alabama. And to give you context, to give you context, in 1932, these men signed up for a medical study under the guise of receiving free medical care. And to give you a little more background information, these 600 men that signed up, these were all sharecroppers that were extremely poor and had never seen a doctor in their day. So the enticement of having free medical care probably was enough for them to say yes to the medical study without even knowing what the medical study was. But they did not explain what the medical study was to these 600 black men, and they infected half of the men with syphilis without telling them, and then prevented them from receiving medical care for over 40 years to see the full impacts of syphilis. By the time the story leaked out to the mainstream media, 28 men had died due to the disease, 100 men had died due to complications, and 19 of their children had the disease as well from birth. Um, the participants and their affected loved ones are still living in recent modern times, with the last participant dying as recently as 2004. So their children and their grandchildren and their children, which might still be infected with syphilis, are like currently living today, right now in society. Like when people say medical racism is a thing of the past, it really is not. Like it's just a corner away and it's still existing in our healthcare system today. And the next case study I wanted to bring up was Walter Freeman. Walter Freeman was the president of the Medical Society of the District of Columbia, so essentially our capital, in the 1940s. And he actually advocated and tried to volunteer Black patients into getting forced lobotomies. He truly thought that Black psychiatric patients, especially Black women, were among the best candidates for lobotomy because Black families would be the most likely to provide quality care to their relatives post lobotomy. So he thought Black patients would be really good lobotomy candidates because they would have people to take care of them afterwards. You know how insane of a reasoning that is? Like that has no logical train of thought to me personally. I don't know what he was thinking, but that's like this is the president of the Medical Society of DC. Like, and he advocated Black people to be candidates for that reasoning. Yeah. And it gets even worse. So he was also extremely happy at how lobotomies turned out within his Black patients. At the West Virginia State Hospital in Lincoln, he performed several lobotomies on Black patients, and he was ecstatic to see that 20 of his so-called labeled dangerous Black patients had been lobotomized by him, and now 15 of them were senile and acceptable to society. Yeah, that's literally all I have to say because that is quite racist and horrible. And moving into the next racist and horrible doctor is J. Marion Sims. Essentially, the entire field of gynecology is built off of racism in America and contributed to these medical myths about BIPOC patients that are still currently existing in our medical schools today. And I'll touch on that later. J. Marion Sims, the father of American gynecology, repeatedly experimented on 3 Black women forcefully to refine his surgical techniques, which are still in use today in our OR rooms, like within modern gynecological practices. These 3 women called Anarcha, Betsy, and Lucy were repeatedly operated on over the course of 4 years without anesthesia or pain medication. And let me remind you, they're not on anesthesia or pain medication. And records show that they were operated up to 30 times over the course of 4 years without anesthesia or pain medication. So he was essentially using them as living cadavers for his surgical techniques. And you know what's even crazier is that in 2018, a statue of J. Marion Sims was finally taken down due to public outrage for his actual like crimes against humanity. I can't believe the statue was still even up until 2018. Like that just shows how racism is still very pertinent in America. And that transitions into our next topic that I wanted to talk about. Our next main topic that we will be talking about is racism affecting patients, which perfectly transitions from our last topic. Yes. So the social categorization of individuals into racial groups has devastating effects on their healthcare and medical treatments. In contemporary medical literature and coursework, biological misconceptions about racial groups are being taught to healthcare professionals. So, in 2011, an evaluation of a popular medical textbook, Robbins and Cochrane Pathologic Basis of Disease, 8th edition, reviewed that 20 of the 31 claims associating African heritage with specific diseases were either false or had no supporting evidence. And another study showed that UWorld Step 1 Q Bank, which is a widely used preparatory resource for the USMLE, which is like the board examinations for medical students. The UWorld Step 1 Q Bank was shown to use race as a crucial factor for the diagnosis of racial minorities. An assessment conducted in 2017 of the program's usage of race and ethnicity showed that the racial categorization of white and Caucasian was crucial for diagnosis for only 7.4% of the time, while the term Native American / Indigenous was 100% essential for diagnosis, which shows you how racialized diagnosis in certain conditions are within medical treatment today. Like, this is literally a popular preparatory resource that is still used for medical school examinations today. Like, I don't think anything's really changed. This study was published in 2022. So, and in medical textbooks, racial minorities continue to be severely underrepresented within visual depictions of medical conditions and diseases, leading to high rates of misdiagnosis. So, in a 2020 study of dermatological textbooks, only 18% of images depicting skin conditions and diseases had darker skin tones. Another study in 2018 found that less than 5% of images in general medicine literature contained darker skin tones. By using images primarily composed of lighter skin tones, healthcare professionals assume that these diseases don't exist in dark skinned individuals, or they won't be able to recognize them in affected individuals because they literally have no reference images. Like, common sense, people, please. Like, it is, this was in 2020 and 2018. Like, that is crazy that there is less than 5% of images in general medicine literature with darker skin tones. Like, come on. And this was even crazier. Modern medical equipment also continues to perpetuate that biological differences between races exist. So spirometers, this is something I learned in my previous lab that I was in. My PI taught me it. Spirometers, which are lung function measuring devices that measure someone's lung capacity, apply a racial correction for patients of different ethnic backgrounds. The device automatically estimates Black patients to have 10 to 15% less lung capacity, and Asian patients to have 4 to 6% less lung capacity in comparison to white / Caucasian patients, which stems from the racialized medical myths that are ingrained into medicine due to like white Caucasian patients being the top tier pedestal. So they have to have like the best biological characteristics of any patient. Yeah. And we'll see that later on. Additionally, many physicians are typically unaware that these racial corrections are applied to such spirometer measurements, which is so concerning. Like, that means your doctor could be measuring your lung capacity and they don't even know that the device is automatically applying these racial corrections onto your measurements. Yeah. And that's just, when I learned about this, it was just shocking because these spirometers are still being used today in medical offices. And mm, speaking of, we are going to transition into healthcare professionals because they also carry their own racial biases. So, healthcare professionals also carry their own preconceived racial biases that drastically affect their patient care and medical decisions. Um, in 2016, a study was conducted on 222 white medical students and residents from the University of Virginia. Mind you, this is in 2016. And they conducted this study to investigate the prevalence of false biological misconceptions that medical students and residents might have about their patients. Um, some of the biological misconceptions presented were were Black patients having thicker skin, stronger immune systems, and denser bones in comparison to white patients. As I said earlier, um, medicine has really reinforced this idea that white patients are the most superior biologically. And according to the study, 50% of the participants said that at least one of the biological misconceptions, such as thicker skin, stronger immune systems, and denser bones, and higher pain tolerance, were likely or undoubtedly true. So let me reinstate that again. 50% of the participants, which are all white medical students and residents from the University of Virginia in 2016, said one of these huge biological misconceptions about a Black patient was likely or 100% true. These racial misconceptions are widely mistaken as facts by healthcare professionals, and this translates into immense inequitable healthcare. So, in 2015, a study looking at approximately a million children diagnosed with appendicitis looked at said that Black children with moderate pain were less likely to receive any pain medication at all, and Black children with severe pain were less likely to receive opioids in comparison to their white counterparts. And this is because a lot of doctors today have this biological misconception of Black patients that they have higher pain tolerance, and we can connect that back to J. Marion Sims, as I said earlier. He really bragged about his patients, like his 3 women that he experimented on, having really high pain tolerance, and that Black women were the best candidates to perform surgery on because they had higher pain tolerance. And as we can see, these misconceptions still persist today. And healthcare providers have implicit biases and prejudices against racial minorities, whether they're intentional or not. A 2017 literature review of 37 studies that researched the prevalence of implicit bias in healthcare demonstrated that 31 of the studies had significant evidence of healthcare workers having positive biases towards white slash lighter skinned patients and negative biases towards Black slash Hispanic slash indigenous slash darker skinned patients using results from the implicit association test. So let me give you a rundown what the implicit association test is as someone who has taken it several times as an anthropology major. Um, the implicit association test is essentially they show you 2 images, one of a darker skinned individual, one of a lighter skinned individual, and they test your reaction times to these photos. And essentially, through these reaction times, they can tell which person you prefer, even though you are not purposely trying to choose it. That's why it's called an implicit association test. And if y'all want to take it, I will link it into our resources in our Instagram link tree. Yeah. And these implicit biases are deeply ingrained into society and are super challenging to unteach in healthcare workers without direct interventions and continued education, such as diversity, equity, and inclusion courses, and also anti racist frameworks that are implemented into hospital systems today. And even though race isn't biological, racial classifications have detrimental repercussions that affect an individual's biology. These biological effects can compound and create generational health disparities that worsen over time. Within the United States specifically, cardiovascular disease is a primary cause of death for Indigenous Americans. Indigenous Americans are exposed to significantly higher levels of stress and childhood trauma during their childhood experiences, leading to higher uh, leading to higher rates of cardiovascular disease. Based on a study in 2003, Indigenous Americans are 5 times more likely to have 4 adverse childhood experiences than their non Indigenous counterparts. Oh, sorry, let me reinstate that again. Based on a study in 2003, Indigenous Americans are 5 times more likely to have more than four adverse childhood experiences than their non-Indigenous counterparts. So essentially, they're more likely to have really bad childhood experiences than their non-Indigenous counterparts, which triples the likelihood of developing cardiovascular disease. And Indigenous American women have the highest sexual violence rates of any racial or ethnic group in the United States, and Indigenous men have the highest probability of being murdered due to police brutality in America. These traumatic events contribute to increased PTSD, which then causes other health disorders. Um, in another study conducted by the American Indian Services Utilization Psychiatric Epidemiology Risk and Protective Factors Project, oh my God, what a mouthful. Um, in this study conducted by that project, over 2/3 of individuals living on reservations located in the Southwestern Plains had exposure to significant traumatic events. The PTSD they had from these traumatic events was positively associated with increased rates of obesity, high blood pressure, and cardiovascular disease, which also sets them up for more disease later on as they age. Um, and transitioning into that, we're going to talk about the COVID-19 pandemic because it really showed how structural racism affected healthcare outcomes. Um, during the COVID-19 pandemic, African Americans were dying at significantly higher rates and frequencies. African Americans from Wisconsin made up 20.5% of all COVID-19 deaths in the state, even though they only comprised of 6.3% of the population based on a study conducted by the Kaiser Family Foundation. Um, that's a huge discrepancy, 20.5% of all deaths versus them comprising 6.3% of the population. Um, the extremely high COVID-19 mortality rates of African Americans correlate with systemic racism. African Americans are more likely to develop obesity within their lifetimes because of increased food insecurity and insufficient access to nutritious food resources like the ones we talked about in our nutrition episode. And in comparison to white Americans, African Americans have triple the likelihood of developing asthma. And African Americans have been subjected to redlining and pushed into communities with poor environmental and living conditions, such as sacrifice zones, like we talked about Cancer Alley in the South, like in last episode, which disproportionately increases asthma rates. Increased rates of pre-existing obesity and asthma create this comorbidity, like multiple diseases existing at the same time and affecting each other and increasing their severity. So increased rates of pre-existing obesity and asthma in African Americans can significantly worsen COVID-19 prognosis and mortality. There are also huge disparities in the access and quality of healthcare for African Americans in the United States. Public health officials have hypothesized that the shortage of health insurance for African Americans has significantly increased COVID-19 rates. Additionally, African Americans also live in counties with insufficient amounts of healthcare resources. According to a study done in Georgia, the counties that had the highest COVID-19 death rates also had the largest African American populations and the smallest amount of ICU beds and healthcare workers. A coincidence? I think not. And this leads into racism affecting healthcare workers because that was like everything I wanted to talk about racism affecting patients, but racism also drastically affects healthcare workers as well. Um, Doctors from marginalized communities continue to face backlash for speaking up against racism in healthcare. Um, I have met several doctors that don't like to talk about their experience as a person of color or about what they faced in medical school due to the fear of what might happen like repercussion wise from their hospitals or their educational systems, et cetera, because they just don't want to stir the boat. Um, One person that did stir the boat was uh, Asha Corey, who was an internist who was hired by Kaiser Permanente's medical school in Pasadena, and she was fired from her job after she talked about her personal experiences with racism in the healthcare industry. An individual had submitted an anonymous complaint about her discussion about racism in the healthcare industry, and as a result, she was suspended without warning by the institution. The school issued a statement saying that it had nothing to do with her discussion about racism and equity, but there was no explanation for her suspension, and her employment at the school wasn't renewed. Structural racism has integrated itself into medical education, and POC medical students are at a huge disadvantage in comparison to their white counterparts. Um, I can attest to this as someone who is studying for the MCAT right now and is trying to get into medical school. The entire medical school application process is extremely privileged and requires a lot of money. I mean, there is MCAT tutoring nowadays, interview coaching. People can review your written essays, etc., etc. And this like this this requires a lot of money from the people that are taking the MCAT because these programs can cost up to hundreds of thousands of dollars if you want to pay for it, which requires generational wealth. Um, yeah, and social economic status is a major contributor to high MCAT scores, and medical school applicants from marginalized groups have lower MCAT scores on average. Medical school applicants from marginalized groups also have difficulty accessing extracurricular activities and clinical working experiences and shadowing because to gain clinical working experiences, shadowing, and extracurricular activities, a lot of people use their connections, which are also due to generational wealth and privilege. Yes. Additionally, POC medical school applicants are also subject to racial biases during the interviewing process, which shocked me when I learned about it. Shouldn't have shocked me, but like the prevalence of it shocked me. Um, According to a nationwide survey, 64% of medical students reported a hostile racial environment within medical schools, and the survey also revealed that 81% and 94% of medical students witnessed discrimination towards students or patients by teaching physicians. Medical students from marginalized backgrounds also have higher rates of post graduation debt and stereotype threat, contributing to lower USMLE scores due to increased anxiety. Another study has shown that Black medical students have the highest rates of stereotype threat at 82% in comparison to their white counterparts at 4%. So you can see how their anxiety levels would drastically change um, when taking these tests, which are crucial in medical school. Like you constantly take tests. So having anxiety due to your race at all times is quite debilitating, to be honest. Um, Black students are also more likely to be described with neutral adjectives such as competent, but white students are also more likely to be described with extra positive adjectives such as outstanding or superb during evaluations. As we can see, that might be due to implicit biases. Um, and additionally, during residency matching, Black and Indigenous medical students are influenced into becoming primary care physicians to serve their underrepresented communities. However, they become burdened with debt in comparison to white or Asian students going into higher paying competitive specialties. And I have a lot to say about this because I don't think Black and Indigenous students should be bearing the burden of their communities and be forced to serve their communities only, especially since white and Asian students are being allowed to like go into these higher paying competitive specialties. So Black and Indigenous medical students, it's I think it's really good to service your own communities, but I don't think they should be pressured into serving the communities just so that their people can receive proper care. Like that is really horrible, and people should be able to pursue their own dreams and specialties as they want. Um, and the trials and tribulations that POC medical students have gone through have led them to having worse mental health outcomes. A nationwide study conducted with a diverse group of medical students has shown that hostile racial environments has worsened depressions for medical students of all backgrounds, regardless of their race. So, racism in medical schools has been negatively affecting students' depressions of all races, their white counterparts, and POC medical students as well. And that about wraps up everything I wanted to say on this topic. But as you can clearly see, um, medical racism in healthcare and healthcare workers really does affect healthcare outcomes, and that is what we are going to transition into our discussion. So, um, thank you so much for listening, and then you're going to hear me talk some more in like about a few seconds. Thank you. Okay. Thank you everybody for listening. I know that was a lot of my voice. I think like you just listened to me like talk for like a good 30 minutes, which I would not listen to myself talk for a good 30 minutes, but thank you for bearing with it. And hopefully you learned something. And now we're going to get into the discussion questions, which is going to be a little complex, but I will lead y'all through it. So, first I wanted to ask everybody, what was your favorite part about my, little rant about medical racism and medical anthropology, and what was most interesting thing that you learned?
It was very crazy to hear and remind myself of the things that were normalized before. What was crazy for me to hear and like kind of grasp was the non-consensual practices on people of color that was going on for 6 years is insanity. And I was wondering if that was a hidden truth, or was it disregarded, was it just normalized when it was known? Yeah.
Oh, to answer that question, it was actually very normalized when it was known. There are several protest and art posters that are archived in our government like records today that show that black and brown people did protest against this because everyone knew everyone knew that they were getting hysterectomies and forced lobotomies, but no one really cared because they viewed them as savages and primitive, and they were allowed to be brutalized because they weren't even seen as human. They were technically below animals in their eyes. So whatever medical procedures they wanted to do, they really just didn't care because the white the white medicinal system just viewed them as bodies to practice on. Yeah.
To
Okay.
clarify, can you briefly explain what hysterectom, how do you pronounce that?
Hysterectomy.
Yes, can you, to clarify, can you briefly explain what a hysterectomy and lobotomy is?
Okay, so a hysterectomy is essentially the removal of a woman's uterus so they cannot give birth for longer. They use it for uterine complications in women nowadays, but back in the days it was to sterilize women so they can give birth because they didn't want more minority children coming out, and they wanted to like completely like do essentially enact genocide on all these like minority groups, especially Indigenous Americans. Like I stated in my talk, I didn't know this. I literally was like completely shocked when I researched this. Like 1 out of 4 Indigenous Americans in the freaking like 70s like were completely sterilized because they took their uteruses out of 1 out of 4 patients. So yeah, and then for lobotomies, so what they did for lobotomies back in the day, they essentially took like a little pick, shoved it in your eye, and then they scrambled your frontal lobe, so you wouldn't have any more like emotional processing or whatever, so you would become sterilized or desensitized in their eyes. So when I was talking about that, the doctor who is the president of like the Columbia Medical Society, he called black patients like savages and aggressive and dangerous. And then after lobotomies, after scrambling the brains, then he considered them to be like neutralized in a sense. Yeah, so that's and lobotomies are not practiced anymore. they are not typically recommended because it does turn you into like a shell of yourself because you are essentially scrambling someone's brain.
Um, yeah, so I thought it was really important that you stated how recent everything was. Like, I feel like a lot of times, like when we talk about these kinds of things, it's always talked about as like archaic and like it happened so long ago. Like this is not normal anymore. And I think it was super important how you brought up that like this stuff happened really recently. Like there are people who are still alive who experience these like atrocities, and like a lot of this is still like ingrained in our medical practices. Um, I also wanted to comment on how intersectional all of these issues are. Like the forced sterilization of black women and BIPOC women, like that's such a big like feminist issue too. Um, I think it's super important to acknowledge that, and also the like the racism against indigenous people. Um, you said something that like kind of clicked with me like just now, where like there was this big movement to like erase these people's like culture as well. Um, like I think in they used to have like schools for like re-educating uh, indigenous people, and they would say like kill the Indian, save the person, or like kill the Indian, save the man, which is like so fucked up like that. Yeah. So I think it just goes to show how interconnected everything is, and how like people were not viewed, or certain people were not viewed as people. In yeah.
I really am happy you brought up the Canadian residential schools. Actually, that was a very recent development. They are still finding Indigenous bodies, mass graves behind these schools because, as I said, they really don't care about them as people. That's what you learn about anthropology. The Western colonial system views everyone else as savages and sub beneath human, which is really good for enacting genocide. So, um, yeah, but really glad to hear that. And also the intersectionality. I should do more research on if white feminist movements were caring about forced sterilization back in the day. That is a very interesting topic to look into.
Yeah, so I come from a background of global health. That's my area of study. So like a big part of that is like the intersections with medical anthropology. So I've like learned about this. This is like something I'm passionate about as like with Matthew. Like this is something the both of us want to change in our future careers. And Matthew, I just really appreciated how you like simplified everything and like it's like a lot to summarize into a like 30-minute interview. It's not easy, and the way you did it was just really really well done. But like I really also appreciated how you talked about the other side of the story, how this is affecting like current medical students, current physicians, and like what the impact it has on them, like mentally as well as like in their career. I believe you talked about a doctor that couldn't like she spoke out about like the issues that she faced in the community and like with racism and how she was penalized for it. Like I think just talking about that is just so important, and then us as future healthcare workers are like recognizing that there's so much change that needs to be made.
Yeah, and I also just want thank you for mentioning that, Jasmine, because I just wanted to bring that up because um I like we are gonna be like hopefully future medical students, and these are gonna be our colleagues that we're gonna be working with. So that's also really concerning, just knowing the general environment within the medical system today, especially in America where it's so racialized. And also thank you for talking about Aisha because she is just one of the many cases that I could bring up because last week I think a Palestinian nurse was just fired from NYU medical facility for speaking up against dying mothers in the Gaza Strip. So it's still very much happening today. Yeah.
So yeah, I agree with Arem and or like the points that Arem and June brought up about your talk bringing up the history of medical racism. Um, Something that really stood out to me was like essentially fabricated data coming from professional medical devices. Like when you're talking about spirometers, I thought it was really concerning and interesting to bring awareness to, especially since professionals using these devices also don't know of the inaccuracies in these measurements, which ultimately enforces the biases in healthcare, especially when data from these devices show correlations that favor a certain racial narrative.
Yes, that was actually one of my favorite things to like learn about when I was in my like studying medical anthropology, because a lot of these racial corrections are just applied without us knowing, or a lot of these medical myths are still enacted today, because I hear from my mom especially, like some of her nurse friends think that Black people genuinely need less pain medication, or they're just coming in to seek pain medication because they're addicted to drugs. That's it, in the ER, which is terrifying, because all of those are false myths, and then we'll get into this later. But like I mentioned, like the study with like the white medical students at University of Virginia, like 50% of them believed that one of these myths were 100% true, which is, this was in 2016, by the way, so this is like literally 8 years ago, and they're probably practicing medicine right now. So yeah, but that's why I advocate for diversity, equity, and inclusion classes all the time. Yeah.
I had a couple comments and questions. So firstly, Vicky brought up the spirometer. Um, I actually learned about spirometers like very briefly in my like physiology course, I think, and it was like incredibly shocking to me that like you said that these spirometers, they have like different things for different races, which is like absolutely insane. Because like this tool was presented to me like as a completely objective like measure of like lung capacity and that kind of thing. So I think it's crazy. Like these are supposed to provide accurate like scientific readings, and it's what's being taught in schools, and they have implicit biases or like ingrained into their design. Uh, and then I forgot my second comment, but my question is like, you mentioned the fact that like everyone has implicit biases, and like these biases are super important in medicine, and without like active and like frequent education efforts, people would continue to hold these biases. What do those active and like frequent measures look like?
Oh, okay. So I actually did research on, I did a lot of research on everything. My God. Okay, I did research on this, and I was looking at one of my projects was to look at how different universities are concurring against this. UCSC is actually one of them. They actually have pretty decent education program. They require medical students to take like at least 2 diversity, equity, inclusion courses, I think. And you can work at the border with immigrants, like trying to donate supplies and working at their free clinic in like San Diego, or there's like immigrant refugee health, servicing free clinics like during Chinese New Year to like Vietnamese and Chinese patients, et cetera, et cetera. And I know Emory University, they have like they make students take the implicit bias test, and then they have like people come in and give lectures about it. And I know some schools also do book clubs and stuff led by people of color medical students. I have a little grip with that as well, because that's like a whole nother issue, because a lot of people expect like these BIPOC medical students to take on the entire load of educating their fellow peers themselves, and not the responsibility of the school, which I have beef with. But yeah, I think like I think in acting courses and making people have like real life experiences with people of color is like the most important part, and also acknowledging that these implicit biases exist. But I don't think like trying to give a recommended book reading, like recommended book list to your medical students, is like the most active thing you could possibly do to counteract against anti-racism. And this is also a fact that I learned while like last fall quarter, is that most medical schools do not require medical racism to be taught. Like there is no standard for medical racism to be taught at all in any of these schools. And it's quite shocking, really. And also, I was about to, I forgot what I was gonna say. God damn it. But yeah, these like they didn't give like a shit about it until obviously the George Floyd protest happened, and then it became a thing of severity. Like I said, there was a huge, massive trend shift towards anti-racism. But enacting anti-racism policies is a lot harder than most people think. Yeah.
Yeah, I think like adding on to what Matthew said, like changing the education system for medical students or for healthcare students in general, whether you're going to PA school, physical therapy school, like anyone who's interacting with a patient should be going through like DEI courses, and it should be a requirement, and like continued education after they graduate from medical school, like continued trainings like during residency, during like their fellowship, while they're practicing, like is just so important, and like continuous reflection too. And then I think another thing that's also important is like changing like pre-med pre-health requirements to include like anthropology, global health, public health, like sociology, like the social sciences that talk about these issues. Because like if I was solely going like as a pre-med student focusing on the coursework that is required for me to get into medical school, I would not be exposed to these type of issues. And like I think by ingraining like our like schools ingraining in our heads like, oh, you just have to focus on your like ochem stuff, your biochem stuff, and not really understanding like you need personal skills, you need people skills, you need to know empathy and like what these communities are going through before you even enter medical school is just so important. Like consider it like a weeder course, I guess. Like you need that education before you go into med school.
Yeah, and I feel like it's really built into the testing systems are in the medical system nowadays, because as we can clearly see on the MCAT, there's like 8 different sections, I think, and only one of them features like social sciences, and the rest of them are primarily very hard STEM. So like obviously the incentive for medical students is not there to study social sciences, and a lot of doctors nowadays don't even typically realize the intersection of like the patient behind patient care, because medicine is supposed to be holistic. But I know this is going to perfectly transition to the next question I have. But a lot of doctors just view like patients as a one and done thing. Once you diagnose them, it's move on next. But they are actually a fully realized individual that needs a set care plan that fits to their tailored needs. That's what medicine should be, but it isn't nowadays because of American healthcare. Yeah, but that perfectly transitions into my next question. How have your previous experiences with doctors or the healthcare system been? And have you had positive experiences with doctors, or have you had negative experiences with doctors? Are you neutral? Give me everything. Yeah.
I can speak about it first. I think I've personally been very fortunate to be, or like to have been cared by like physicians or like medical staff that have always been women and women of color specifically. And I think for me, that has led to like a positive experience because they're able to relate to my experiences. I can talk about my culture being a factor into like my medical health, talk about my family history without feeling like stigmatized against. And I think that's just, yeah, I've been fortunate in that sense. So like positive emotions and like positive experiences from my personal standpoint, but like coming into like high school, coming into college, like learning that this isn't the case for everyone was truly like a big shock for me. And it's one of the reasons why I'm like, okay, like this can't like be an issue like anymore. Like we have to fix this.
Yeah, I feel like I'm in a pretty similar position where I haven't personally experienced like incredibly bad things with doctors, especially in terms of my race. Um, my my mom has like healthcare that is like Korean American medical group, so it's like I'm very lucky to be able to go to doctors um, that like kind of understand what my background would be. But yeah, like Jasmine said, like I was definitely shocked when I heard that like that experience is not universal. Um, yeah.
I also feel very fortunate and lucky to not have had negative experiences with the doctors that I have been seen with, whether it's in the US or in Turkey, my home country. Um, but I would appreciate if I were to have more face-to-face time with the doctors that I'm seeing about any of my health problems. It's always been that you go in and out and they the data and then you're just out, and then they go move on to the next patient. It also makes me feel worried for the doctors as well. Are they how are they able, it's kind of like they're kind of acting like robots in my eyes. There's not much emotional connection to the patient is what I've noticed, and I would appreciate if there was more of that. um another negative experience, I actually not another, but I guess a negative experience would be in the US, the date that the soonest date that they're able to give some patients in terms of um okay, for example, as a personal experience, I was having some sort of a neurological problem and I went to the doctor and she referred me to a specialist, and I tried to get an appointment as soon as possible because the doctor who referred me to the specialist was also concerned, and I knew I needed to see a doctor really quickly. But I still have not seen a specialist because the earliest date that was given to me to see the doctor was in November, and I was referred to the specialist in April. And so even if it was like a video call, it would have been they told me the earliest date would have been in July. But here's the issue. My insurance is with the UCSD insurance, so it's a UC ship. And as I'm graduating in a week, I will no longer have the insurance. So even if I were to accept the soonest date to see the specialized doctor, I would not be able to take advantage of the insurance. So who knows how costly it would be for an unknown diagnosis. Like who knows what the prices will be. And due to that concern, I will be choosing to seek healthcare in my hometown country in Turkey because I know that the prices will be more manageable and affordable. And yeah, the prices scare me, the unknown prices, because you don't know what they're gonna put on the receipt.
Iram, you have a future in medical anthropology. I feel like you would love to take a class. That was really good stuff. But I have similar experiences with that too. Literally last like 2 weeks ago, it took me freaking like 3 whole months to schedule an appointment with the travel clinic so I could get my travel vaccines. And oh my God, like it was just like freaking like trying to like call every single day for an appointment. And it was only a telehealth appointment too. And they didn't have bookings for the next 3 months until like someone randomly canceled. And insurance, as someone who works as a caregiver, oh my God, booking up doctor's appointments is like the most headache inducing, like exploding thing for somebody, especially for like people that are like not able to do it independently themselves. I don't even know how the healthcare system expects people to make their own appointments if like they're younger or older or they're disabled. Like that's so crazy to me, and unless they have a social worker or a caregiver. But yeah, and also the price too, Iram. Crazy as hell. I checked out the price before insurance covered it. Each vaccination was like $300, and I was only there for like 5 minutes tops. Like I was in the waiting room longer than I was actually talking to a doctor, and I didn't talk to a doctor. It was literally just a nurse's visit. So yeah, I feel like, as I said, I feel like the patient inpatient care is just not existent in the US healthcare and specifically insurance system today. Like it's just, and there needs to be a major restructuring of how health is viewed within like billing practices. Yeah.
So for my experience, it's been like pretty neutral. Like whenever I would go to the doctor, it was just like a regular checkup, and like Arem said, it wasn't like very personal with the doctor, which honestly I think is really important to have that connection so that you're not like so you're like more trusting of your healthcare provider and more inclined to like tell them when something is wrong. Like whenever my doctor asks if anything's wrong, I'm just like, no, like I don't want to be a bother or whatever, because they're always like in a rush doing their procedures every day and like getting through each patient. So yeah, that's been my experience. Also, fortunately, nothing negative. But yeah, that's been what I've experienced.
if it's okay, I'd like to go on a rant. So Matthew and Aram, you guys brought up some really good points that like that frustrate me. Because like again, like this is what like I want to go into healthcare administration in the future, and this is the stuff that I want to change. But so one of the things you guys were talking about was lack of empathetic care. And like that's because our like doctors are working like 80-hour work weeks, not getting like enough shift times, not getting to go home in the meantime. They're being desensitized to like emotions, like, and especially if you look at like emergency workers or people who are constantly working in the fields where death is a common thing, they're not allowed to express their emotions. It's like you see a lot of videos of like doctors on Instagram or TikTok speaking out, or like healthcare workers speaking out about being like, oh, like, yeah, I guess like it's like sarcastically they're like, oh, I cried after like I just lost a patient, but I guess I'm a bad like physician or doctor for doing that. And it's like that like emphasis or like that pressure to be a perfect person but not like kind of understand your human like emotions like as a doctor is what prevents those empathetic connections for your patients. And like restructuring that and recognizing the burden that we're putting on our healthcare workers is so important for us to get the patient care that we want. And then another thing was like the lack of being able to see specialists and resident like primary care physicians. And like a lot of that comes from just not having enough doctors to support our population. Our population is on the rise, and as like even medical education continues, like the price of medical education continues to grow, a lot of doctors tend to go towards more specialist fields as opposed to like primary care, for example. And we know that every person should have a primary care physician in the ideal like patient home system. But like because so many people are going for specializations, like we don't have enough primary care physicians, we don't have many people like being able to, so it means like one doctor is seeing so many patients at once, can't really focus on it. There's like a poor continuity of care. And then if you look at like our insurance systems are actually affecting the residency spots that open up, which means that they're affecting how many doctors are in each like field of practice. So for example, like I think it's, I don't remember if it's Medicaid or Medicare, but they essentially set like, oh, like for this year we're going to have this many OBG like openings, this many like pediatrics openings. And like seeing that like that is an issue, like is how we can move forward to like getting more doctors into the field and like less gatekeeping.
And that actually relates to something that I said in an interview, because a lot of people expect these BIPOC students to become primary care doctors and pediatricians, etc., like the lower end specialties, because they should bear the burden of their community, and they're not allowed to pursue higher specialties, like more prestigious specialties, such like white and Asian medical students too. And white and Asian medical students typically have the financial privilege to do that because they don't have to pay off debt later on. That's why. So, and also, it's just crazy to me to see like the shortage of doctors right now, as they're going to bring out the residency shortage, and also like the amount of shortage in certain specialties as well because of the stigma in those specialties. And I did not learn this until I took my class, but gerontology is not taught at all, like in medical schools. Like it's not required as clinical rotation. And also there is like a 40% shortage of geriatricians right now because people just view death as an icky topic to like ever want to deal with. So the stigma and prestige in medicine is just so crazy, specifically in America, because everything is regulated by the government or the insurance, where people like my client tells me like the best way to be a doctor is to genuinely just listen to your patients. But that like patient care aspect of listening and communicating and having time, face-to-face time with your patients, is being eradicated like every single day. And also now there's like this new argument of like AI doctors and having AI primary care physicians, but I feel like that's going to really erode the patient care relationship with your doctor even more so. Like y'all said, like you don't even get to like fully open up to your doctor for your feelings or how you typically like would want to say stuff because you feel like a bother. But I feel like having like more desensitized stuff is just going to really ruin like that's not a good way to go towards for the future of medicine in this country.
Yeah, I kind of want to comment on the like person to person aspect of patient care. Um, I recent or like semi recently, I was in and out of hospitals like a lot. I dislocated my shoulder, and so I had to get surgery for that. And thankfully, I'm all better now. But like uh, during that time, it was really hard to go and meet like different physicians and speak to these people that I essentially don't know. Like I've never seen this person before in my entire life, and they're expecting me to like tell me or tell them exactly how I'm feeling and like what's wrong with me, so that they can like create a plan for me. And it's hard to do that. And really, I only felt like cared for, um, or the time when I felt the most like comfort in my care was when I started getting like PT and like started regularly seeing the same PT like every week. Um, like I felt like I could tell him like exactly how I was feeling, and like it established a baseline so that I knew when it deviated, like was it better, was it worse? And I think that's something that's like kind of missing since like it's so expensive and so infrequent when you get care. It really deters people from getting those like monthly or like weekly checkups that like or not weekly but like more often. You know, people should be having checkups and they often don't because of the cost and because of that barrier. um so yeah, I feel like that like person to person aspect of care is just so important, and it's so like missed. Like it does not happen that much. Yeah.
Yes. And then I wanted to transition into the next question. Like, if y'all are receiving care from these doctors, do you ever, like, since I mentioned implicit biases in doctors, do you ever, like, in the past thought about how your doctors might have implicit biases against you or towards you? Or, like, do you prefer a certain primary care doctor or a certain doctor of certain ethnicity, race, because you feel like they're going to relate to you more culturally? I just wanted to hear y'all's thoughts about that.
Yeah, so I like mentioned this before. Like I definitely prefer like having a woman of color as my doctor or like healthcare provider. Just just like as June was saying, like it was hard for him to like establish a baseline connection. For me, I feel like it's easier for me to establish a baseline connection with a doctor that like who I've like there's so many intersections with my identity. So I think that's been really important for my care and like also the care I want to provide for the future.
For me, not so much culturally, but I look for or I want to have care from female physicians rather than male physicians because I feel more understood and empathized and cared for in a different level compared to male physicians.
I
You got
agree.
it.
Sorry.
No,
Yeah, I agree with Aram. Like, I feel like for me, gender is more important. But for my family members who are not English speaking, races like or ethnicity is really important for them due to the language barrier. It's like hard to communicate health issues and like translating everything properly so that both sides understand each other. Like my grandma, there aren't a lot of Asian, or like we weren't able to find many Asian like healthcare providers where I lived in like Santa Barbara, and she um, would have to go to like Irvine, which is like a over 3-ish hour drive to just seek like um, a healthcare professional to get like the treatment she needed.
yeah, I've had similar experiences with healthcare professionals. Like my parents, since they don't or they do speak English, but they're not the most comfortable with it. So they prefer to be seen by Korean speaking doctors. And I actually go to the same like primary care physician as them, and I found it difficult to communicate with him. Um, and I feel like their clinic has some issues that make me reluctant to seek care from them. Um, but like like for my parents, I think that aspect of being able to communicate effectively with their primary care physician is just so important that despite these issues, they kind of stay out of convenience.
For me personally, I would prefer to see a queer doctor. That was like something really hard growing up that I didn't have having, because when they ask you, like growing up, like as a teen, they ask you about your sexual activity, they ask you about who you're seeing. It's always very heteronormative, so that just completely shuts off everything I want to say already. And then you also have the fear of like being outed to your parents as well, because you never know if they're going to follow HIPAA regulations. So I feel like I would have loved to see more gender diversity and also queer representation in doctors. And I also grew up very like in a very primarily white town and county. So all my doctors were very white. So and whenever I was speaking to them, I felt like they were just trying to give me more medicine and more solutions, but not actually thinking about how I feel about these care plans moving forward, which is what I would love to see in the future of medicine. Yeah, but hopefully more queer doctors in the future. Hopefully more people. Yeah, more non-binary people. Yeah. And then
I have a question
yeah.
relating to that. Like for those of you who are pursuing medicine or a medical field, do you guys find it encouraging when someone that intersects with your identities is like you see someone that intersects with your identities in the field that you're pursuing, and like, is it discouraging to see when you go to like seek treatment or something, like nobody that intersects with your identities there?
100%. Like it, like for me, like seeing a brown, like an Indian doctor, like a woman who's like in a high position is just has been so like important to me and my decisions to go into medicine. Even though like our like like even though like Indians are like represented in medicine really well, like it's a like we have a lot of representation there. I feel like just being able to interact with them directly is a whole different aspect, and it shows you like there's like someone who aligns with my values, my goals is like they're representing, and like I can do the same. So yes, it's very important.
Yeah, I feel like sexuality and gender is like a really sensitive topic, especially once you're growing up. Like, especially even if you're older, like sexuality is like non-existent, like to Americans apparently for older people. So, I feel like I would have loved to see more queer doctors and just like I would love to be a queer doctor in the medical field today, but I also know the stigma that's going to come with it, especially from patients and also like I've talked to a queer doctor before, and they tell you all the things that you're going to endure in medical school because once you're practicing with like in your rotations with your physicians and stuff, you really have no control over it. So you would rather put yourself back in the closet than have them have implicit biases towards you, and then they make your life a living hell. So, especially in like I know people go all over the country for medical school, and I know LGBTQ laws in different states are not the same. Like California is very, very like cushy. So, but some people go to medical school in Texas, Oklahoma, like Tennessee, Alabama, where these like people will criminalize any single like queer like actions, or they will have, even if they don't like have like explicitly say it, they will still have it in their hearts. So it's just better like to go back in the closet than to actually express yourself fully, which is very sad, obviously, but you know, safety purposes. And then this also transitions into my next question. Do you think hospitals and clinics and etc. like programs for like CNAs, medical assistants, doctors, nurses, PAs should have continued educations for DEI courses such as medical anthropology, sociology, medical ethics for existing healthcare workers? Because this is actually a really good solution that can be done, because all these professionals need to get their license renewed all the time. I need to renew my CNA license. Like that's I've been putting that off because I didn't get my continued education units. But they do have continued education units, so this would be a great way to implement some of these things. What are y'all's thoughts?
I think it's a great idea. As long as it is accessible, then it should be done because we always learn things, especially before, prior to getting degrees. We learned so much information, but over time, the information is either forgotten or there's gaps between unlearned things, or yeah, gaps between unlearned things. And um, reviewing the information and talking about it in a more grown, mature state of mind, especially after having had experiences with patients already, and then going back to those educational topics will shed a light on different topics on a deeper level. And I think that is completely necessary.
Thank you, Iram. I did not think of that, like going back and reflecting on your own patient care experiences, like continuously. I feel like that would be really wonderful to have hospital workshops and stuff. But as we can see, they all, like a lot of them mostly only care about productivity. So, and there's, I could just go on and on about this, but I'll let y'all talk first.
Yeah, I think I've been like pretty strong about this before, but yes, like it is very important that we have these type of courses and we continue with these type of courses. But I do want to highlight, like, it's like the courses have to be designed in a good way and you're not like negatively impacting the system or the what you're trying to do, you're not like negatively influencing it. Because like one thing that a lot of people, a lot of school education tends to focus on is like cultural competence, cultural humility, and like there's not much of an understanding that like, hey, you're a human, you cannot fully understand or sympathize, empathize with every culture that's around the world. You're never going to be in their shoes. You're never going to understand that. But like, I think I learned this from my Global Health 148 class. Wonderful, like, class. It's by Brenda Wilson. She's absolutely amazing. She changed my world. But yeah, so like she was basically like, it's not cultural competence or cultural humility that's important. It's structural competence and structural humility. Like, you need to see how culture is intersecting with like our institutions, our medical systems, and like that's what our education should also be focusing on.
I have been dying to answer this question. I wanted to talk about this earlier, but I didn't get around to it. So I might go on a little bit of a rant. Um, but like, so, so in high school, I was very like hard STEM, like, or like, I think early high school, I was very hard STEM and a lot of my friends were too. So I like in that mindset, it's super common for people to think like diversity courses and things like that don't matter at all. Like in my personal experience, at that moment in my life, I was taking a ethnic studies class, and I remember thinking to myself, like, I don't need to take this. Like, this is such a waste of time. In hindsight, like that kind of work is so important, and I think I was incredibly fortunate to have people around me to like pull me out of that mindset. But a lot of people that I encounter in my engineering courses don't have that. Um, I think it's like it's super important to have DEI integrated into not only medicine but other fields as well. Um, it's a career path that I was looking into, but a lot of engineering majors go into designing like biomed systems and like biomed devices. So I think it's incredibly important that these issues are addressed everywhere. Like no matter what field you're in, you have the potential to perpetuate these implicit biases in medicine. Um, like the people that design these devices, like the spirometer is a perfect example. Like if you're not competent in this aspect, like the potential for you designing a device, no matter how well intentioned it is, that perpetuates these biases is huge. Like your implicit biases will influence your design no matter what. And I think it's so incredibly important that these issues are addressed in every field. Like, yeah.
I have a story about like someone not thinking that it's important. Like we changed like our curriculum to include DI. I was like taking a global health class, and then was like before class, and a um kid was talking to someone right in front of me, and he was like, yeah, are you guys actually interested in this type of shit? Like, this is such woke bullshit, like it's not even that important. And I remember just being so shocked that like someone from our generation, like after going through a global pandemic, after going through all these like issues with like racism and everything, like someone can actually think that. And then it like scared me that potentially that this is the person that I could be working with in the future. Like, it's like I'm probably going to be working with a lot of people who don't think this is important, that only focus on the scientific aspect of medicine, and like it's just so frustrating to me.
Also, we've been mentioning a lot, but I just want to put out there for any of our audiences who doesn't know, DEI courses refer to diversity, equity, and inclusion courses, and they're very important for the communities and population.
Yeah, it's just really hard. Like in anthropology, we talk about being very human centered and being human positive, humanist, etc. It's just really hard because people just don't give a shit about something until it happens to them. That's like the lesson of like all history. People just don't give a shit unless it happens to them because intersectionality is such a hard concept for people to process. Like, it's just like, oh my God, especially for the system we live in today. But yeah, I think DEI courses should be implemented. I think we are taking positive steps towards that, but I also want the creators and implementers of these like the schools promoting DEI to also be reminded that you need to practice what you preach. Um and not just have it as like this show off thing. You can just like tell people, hey, come to our school because we have DEI. There are actual people behind this and there are actual lives being affected by DEI. So it's not something that you can just put a label on. Like, this is something that is drastically influential to tons of systems worldwide. So
Yeah. I feel like I also want to comment on the DEI courses at UCSD. I feel like the way they're categorized is not necessarily the way they should be categorized. Like, I think the DI class that I took was like managing diverse teams, which I took it, yeah, and like it had like a little bit of DEI, but a lot of it was just about like how to work in a team with like people who are like slightly different from you, and I feel like it didn't really tackle the hard hitting concepts that it should have, or like the way um, I personally would want DEI to. Um, like I feel like there's so much more to be done in terms of like educating people, and it's disappointing to see that the the university requirements for DEI are just so lax. Like, not that like every class should be like incredibly difficult to get an A in or like something like that. I just think like the topics that they cover should be um, more geared for like teaching about the ethical and like moral implications of diversity, equity, and inclusion.
and another grip I have with DEI is, why does DEI have to be limited to these certain courses? Why isn't it already implemented in every single course? Like, why is DEI separate from a science class? They are completely one and the same. They should be like, but then in a STEM class at UCSD, you would never hear an ounce of anything about DEI. Or like, I only had like two professors where they actually cared, and then one of them actually mentioned Henrietta Lacks cells and mentioned black doctors and etc. But I feel like that should be the basic bare minimum standard for these science classes, because science itself was built off of racialized bodies. So I feel like that's just, it should be addressed like throughout like your entire education system, right from elementary all the way to post grad, etc.
Sorry, I don't mean to like. I feel like I'm talking way too much, but uh, I was talking to one of my friends who's in my like engineering class, and he was telling me that in one of him and like his friends' project courses, they had like a day where they were talking about like moral and ethical implications of their engineering projects, and some people were just like saying crazy stuff, like as you guys know, ECE, huge industry for defense. Like, I think it's, yeah. Anyways, um, the professor was talking about like AI and how it could be used in war, or like how would you feel if someone used like the technology that you developed in order to profit from war? And someone said like I wouldn't really care. I'm just making the bag. Like whatever they do with my technology is not up to me. And I think that's such an ignorant way of going about it. Um, like no, whether you like it or not, the things that you do have impacts on other people. Like you should have learned that in like second grade. Like it just goes to show how lacking our education is in that regard.
And then I just wanted to ask the next question, like, especially, do you think medicine in the United States is holistic? Like, just to redefine like what holistic means it encompasses not just the biological aspects of a patient, but also their spiritual, their cultural, their mental, emotional, et cetera, all their different aspects that make them a human. Do you think, like, from your experience or what you've heard, et cetera, do you think medicine in the United States is holistic and actually tries to encompass the whole individual, or do you think it just completely shuts it off to just biological processes?
I think I would like to think, yes, it's holistic, but I don't think it really is in terms of like, I think we're too focused on the biomedical aspect of it, and we're not considering the psychosocial model of health. We tend to focus on the problem that a person is having and not the person itself, which I think is an issue. I think for example, I come from a family with very traditional like medicine like views in terms of like a lot of it is like herbal medicine. For me, I had a lot of problems accepting that myself. Like, I won't hide that. Like, I was like, I don't know if there's science to back it. Like, why do I need to like my mom was like, oh, you should take this. Like, you know, like turmeric is like so important for inflammation. I was like, I don't know. Like, is there scientific study for that? And it's like, I think like we're we we're moving along the path of starting to consider people's views, cultures, needs, and like the things that they're going through, but we aren't at that stage yet to fully say that we are holistic. And like I think like right now, especially where we have such a big focus on research, especially scientific research, in our educational system, and like for our healthcare workers, which in a way I want to say it's kind of hindering that aspect of holistic care.
Yeah, I just perfect thing, like literally what I was going to talk about. I was going to define person-centered care. So person-centered care is essentially like looking at someone's behaviors and diagnosis, et cetera, and the way they act, and actually trying to contextualize it to their life experiences, history, et cetera, because that's what makes them your patient. You have to understand them and why they're acting out like in this way, because a lot of people, especially with like dementia, for example, like people act out and they just try to like sedate them, et cetera, without asking why are they acting like this. People don't act the way they act for no reason. They have something behind it, and I feel like medicine should be exemplifying that. But I feel like medicine is slowly starting to go towards this culture care approach, especially since 2020. Like I feel like we're slowly moving in the right direction, but it's just very slow. Yeah.
Yeah, when I think of holistic medical practices, I immediately think of naturopathic doctors. And it also makes me think of the reason why I said physicians like going in and out of their clinical rooms make me think of they're acting in a robotic way because they don't spend that much time getting to know your lifestyle habits and all of that. And I would love to see in the future, or in the near future even, of naturopathic practices and MD practices to be integrated with each other to give it a more holistic approach.
And I feel like when you go to the doctor's office, they don't ever ask you what cultural practices you're doing to like help with your ailments, or like are you trying alternative medicines, et cetera, or if they do give you like a diagnosis and treatment, like is it going to interfere with anything you're doing culturally, et cetera, et cetera. I feel like these would be great questions to include with inpatient care right now. That's not even like a hard thing to do. That's like something you could ask at the end of the exam, or just like that makes the patient trust you more on a holistic basis, instead of like, oh, like, because I think my family, we use so many alternative medicine practices like cupping, oils, ginseng, et cetera, et cetera. But I feel like trying to talk to your doctor about that, it's just like, from my experience, they just view it as like something like that's just a placebo or something that's just crazy. And it just makes you like not even want to talk to your doctor about any of your other social cultural aspects of your life, essentially. Yeah.
Yeah, I wanted to echo a lot of the things that you guys were saying. I feel like my perspective is also very limited because of the culture, or like the point position that I'm in. Um, I feel like in some aspects, like, yes, my experience with medicine was a lot more holistic because I'm an Asian man, and like my doctors were Asian. So I did get to experience, like, my family's Asian, so I did get to experience stuff like cupping and like acupuncture and things like that. Um, but I know generally the view on a lot of those things is uh, not great. Like, people don't believe in it. And then like also because of my culture, like cultural background, I feel like there's not that much focus on like mental health. But I know that at other clinics there are a lot of, like, there is a big focus on mental health, uh, which we can definitely do better in. Yeah, I just feel like generally we are moving in the right direction, but it's progressing pretty slowly.
For me, like, I again didn't have that much of a connection with my doctors in my care. Um, there wasn't much like integration of like my culture either. Um, I think it was mainly just like checking up on physical well-being. The only aspect of like mental health was like the questionnaire that they have you fill out at the beginning, and then but like they don't acknowledge it at all. Like that, I don't really know what they do with the results, but um, yeah, that's basically the only like intersection between um, like spiritual or like emotional or mental well-being with physical health.
And that perfectly transitions into the next question, of which I was going to ask: do you think the biomedicalization of patients, aka reducing the patient down to just their biological diseases, is going to be like the detriment to healthcare in the United States, especially moving forward with our current insurance and healthcare system? Yeah, because as we talked about, like, our insurance system is very, very, very regulatory and strict about certain things. So
I think like the problem, I think yes, the heavy biomedicalization of like our patients' problems is going to affect healthcare and affect livelihoods. And I think like a big part of that is because we reduce the problem to individual choice. For example, if someone's like coming in, like Matthew, in your interview, you talked about like Indigenous Americans like having like high rates of cardiovascular disease, right? Like a lot of doctors would just see the issue, prescribe them some medicines, tell them maybe surgery is an option to consult a specialist, but no one's really, and then tell them, oh, you got to change your diet. Like it's too fatty, it's too much, like you have too much oil in your diet. But like no one's really talking about like, hey, like a lot of them are not in places where they can access like healthy fresh produce. They have to use the like on reservations, they have to use what they are like, what markets are selling, and like that's not always the healthiest option. And so like recognizing that it's not just the individual who's like trying to like, they're not trying to harm their health. Like no one is trying to like make bad decisions and harm themselves in that sense. Like there's always another like factor, and like I think if we don't start to consider that, it's going to be very like, it's going to be a big problem.
And I actually do have a few cases of that. Actually, in a lot of cultures, people view mental health disorders and dementia and Alzheimer's as a personal problem, like it's your fault for not socializing, isolating yourself, etc. And especially in the United States with diabetes in Indigenous Americans, they have created explanatory models within Indigenous culture to explain diabetes as a natural process of life. Like they're just going to, all of them going to get diabetes because that is like the social situations and the food conditions they were raised in, just like they had to come up with an explanatory model to figure out why they were coming up with diabetes. And this causes even like worse barriers in trying to get medical help because since they think it's normalized, they don't want to reach out for treatment, and they also have a huge distrust in the Western medical system as well, because Westernized medicine has like the best reputation, as we can clearly see. And also Western medicine always prides itself on being like more study based, scientific based, et cetera, than Eastern or alternative medicine. So I feel like Western medicine's like Western medicinal practitioners need to like get off their high horse and realize that different cultures practice medicine different ways. Like that is like the one thing I want to ram in. Yeah.
I think Jasmine touched on something that was really interesting to me. Like the idea that nobody is trying to harm their own health, or like most people aren't. Um, like I think that kind of relates to the harm reduction that we talked about. Um, like there's such a stigmatization of these people who have health issues. Like we view them and we're like, they should be doing this better, they should be doing that better. But in reality, it's like the systemic things that are influencing how healthy they are. Um, yeah, I forgot the rest of what I wanted to say, but it relates to harm reduction. Like I think we got to meet people where they're at and like take into account these things.
Okay, I'm just gonna move on to the next question. Yeah. And my second to last question, sorry, this is so long, my God. But do y'all think that healthcare, we talked about depersonalization of healthcare like throughout the whole like discussion already, but do you think healthcare is going to become more depersonalized as we go moving forward in medicine in the United States today? Will people try to prioritize more profit and more productivity from doctors, which would continue exploiting them exponentially and trying to overprescribe patients? Or do you think we have a chance at fixing that?
I think like I don't remember who, it might have been June, who touched up on the point of like AI and technological usage in medicine and how that's becoming a big thing. And I think like in that sense, if we're trying to eradicate like personal connections and primary care physicians by just saying like, oh, like for example, we have an app and like we can provide you care by like touch of a button and like just tell your symptoms and like a doctor will prescribe you medicine, like that's not what medicine is about. Like people crave or people need empathetic care, people need human interactions to feel like that, so they are heard. Like they like in many cases people come into clinic just so someone can listen to their problems, and like that's what they need. And like so I think if we move along the lines of AI and like just trying to streamline everything into like simple like infrastructure, like it's yeah, we're going to move towards depersonalization of medicine.
Yeah, I completely agree. I think a big thing is like recently like telehealth apps, like video call or like text message treatment, um, and like that just isn't enough a lot of the time. Like a lot of conditions require that the physician be there in person to diagnose you. Like an easy example is like an ACL tear. Like you got to go get an MRI, of course, but like there's like a physical test that you can do to see if like you actually tore your ACL or not that you can't do if like you're not in person. Um, so I think it's super important that like you go and see your doctors in person. I do think like the pandemic was a great display of how telehealth and that like digitization can be used as a tool, like in times of when things aren't accessible. It's definitely like an amazing tool. Technology is great that you can use, but it should not replace in-person care.
I completely agree with you, June. I think telehealth is a great option for people that don't have access all the time to doctors, but I feel like it shouldn't be the 100% solution, as I think all technology should not be the 100% solution for every single thing to like bandage every single problem on this earth. And but I feel like telehealth is a good option if you just like you know what you want, like you just need to get a prescription or something and you just need to get in and out. But for like other like consultations, or like you're meeting a doctor for the first time, or like psychiatric care, et cetera, I feel like that's much more personal, or your family doctor that you want to see like for the rest of your life. I feel like telehealth is not the way to do it. Like that requires care and attention, and patients need validation and like to be seen and to feel like they've been medically taken care of. Like it's just a feeling you have inside of you as a patient. Like when you walk on an appointment, you feel like you've been taken care of. Yeah.
I'm just gonna add something really quick about telehealth. Like, I think, like, yeah, like as you guys said, like during the pandemic, like seeing how like quickly we can adapt to the situations was really great. But I also think it showed us like how we can actually influence policy changes, because like telehealth wasn't in practice a lot until the pandemic, where it forced us to do so, and a lot of it was because of laws and regulations of like county laws, state regulations, like that just prevented care from an external like location. Or at the same time, like for example, PAs or like nurse practitioners, like they're like I'm like, I don't have the word for it, but like their ability to like there's like a specific term which I'm not able to recall, but like after the pandemic or during the pandemic, we saw a rise in the like the role that nurse practitioners and PAs can have, and that's because of policy changes. So like if we can do that, we can make the changes like in our medical education curriculum or like in our medical systems. So that's, I think that's just really important to consider.
Yeah, and I think telehealth is very beneficial, but it should not be used to further exploitation of these healthcare professionals. Like it should not be used to push even more productivity from them. So you can just like try to fit people into 5 minute slots all the damn time, like a robot, like Iram said. Like that is not what telehealth should be. And I I'm just concerned that it might be going that way. Like they are not using it for the right purposes. Yeah.
Yeah, I feel like telehealth will be really, really productive in terms of really contagious diseases, or where you're too sick to even get out of bed, or like have fever. Because in my personal experience, this is what had happened to me a year or two ago. I had tonsillitis and I had really high fever, and I couldn't really get out of bed. And then I first for the first time utilized telehealth, and it was really helpful to me. And for those situations, I think it is totally good. But there should be um productive and fair, equitable policies to not overwork the physicians or physician assistants or nurse practitioners, to fit in their extra time, to be more productive, because it won't be productive. They will be burnt out even quicker, and over in the long run, it will not be productive.
Um, yeah, I agree with everything you guys said. Plus, I think a good example of bad telehealth is like, I don't know if you guys have heard of BetterHelp, the therapy like telehealth service. I've heard a lot of controversies surrounding that service, including like people saying, like Matthew said, like therapists trying to force more productivity out of themselves by fitting people into like in between sessions, um, and like not following like correct like HIPAA regulations, things like that. So I think that's a really good example of bad telehealth. Uh, and then also, I wanted to go back to talking about AI a little bit, like AI healthcare. The thing to remember about AI is that like AI can be racist too. The people who make it can have implicit biases that influence the way in which they train the AI. So despite AI being presented as like some sort of objective thing, it's super important to super important to remember that like it all depends on what data you feed it. So if the data you feed it is biased towards like let's say like it's biased towards white people, because that's probably what's going to happen. To be honest, like it's probably not going to pick up certain things in like BIPOC patients. So yeah.
Amazing point, June. That's what I also wanted to talk about. These training data sets, even though people might try to include people of color into these training data sets, they do have implicit biases in them, or they might feed it into the stereotypes of these patients even further. Like I said in my talk, like these data like bank questions for like MCAT studying, et cetera, they already have implicit biases in them. So if you feed it, the information is just going to repeat the cycle. And we already see that in today's like machines, like with hand soap detectors. Like there was a whole controversy with hand soap detectors not recognizing darker skin tones because they can recognize melanin because our training data didn't allow that. So it just makes me concerned for like machines like in robots diagnosing certain diseases in darker skin tones. As I also said, like in textbooks there is barely any representation of darker skin tones already. So how the hell are we going to train machines to do that when we don't even have the data ourselves? Yeah. And lastly, out of this huge ass discussion, I just wanted to ask concluding thoughts on what y'all would personally like to see change in the healthcare system today.
Like literally everything we talked about today. I think like my ideal healthcare system would be to like consider all the problems that we talked about today, and we all presented like solutions, our own personal thoughts and opinions on it, and like just recognizing like these are issues. And I think a big part of it is like we need our future medical doctors, our future physicians, even our current ones, to recognize like how big of an issue it is, and like that, yeah, just overall change, like restructure everything so it's like it's not built for the white man, you know.
Besides like individual practitioners, um, accessibility of healthcare services would be amazing. Uh, Everything is expensive and it sucks and I hate it. Like I have to pay. There's one time I went into the clinic to get my blood test results and they made me pay $20 for that. Like that was crazy. Like they sat me down, took my blood pressure, told me my results. I was out of there in like 10 minutes and they made me pay like $20. That makes no sense. Like yeah, like things need to be more accessible. Um yeah.
This is where I'll say vote. Like make sure the people that you're voting for are like caring about healthcare, especially in the election that's coming up this year. Like yeah, so like just consider like where our funding is going to go, whether we're going to have like proper insurance funding in the future, and like just like women's rights is also a big issue now, so like please consider that when you're making the decisions. So yeah, vote.
So for like the medical student side, based on all the information you provided, I hope that like opportunities in the healthcare field are less limited and less favorable towards wealthy white populations. Like literally every step of one's journey into healthcare, from like getting access to educational resources to the overall professional environment, and um, yeah, just having more diversity in healthcare it's beneficial for both providers and patients, since more perspectives in medicine are just welcomed in the field, which would mediate strong biases that are held by the most prevalent demographics.
Yeah, definitely everything that we have talked about already, like more holistic approaches in medicine, I would like to continuously see. Even doctors, like when we go to get checkups and stuff, them even a little bit educating us about bettering our lifestyle habits or things that we could do better as patients. I think that would be really important to be talked about. And going back to the interview that you provided us, Matthew, I just want to say that to know that these inhumane experiments have happened within the last century really opened my eyes to how policies affect our communities and populations. And as we brought it up in our last episode, and as Jasmine just mentioned, being aware of current practices of our times, raising awareness, and voting are really, really important to shape the world to a better one that is a fair, safe, and equitable one. one.
And then my concluding thoughts is I hope people realize that restructuring is possible within the medical system. Like, we are the ones that created the system, so we can just as easily tear it down. Like, it's not that hard if we have collective action. It's really like everyone always asks this view, why do you want to go into medicine? It's so terrible, et cetera, et cetera. As like a person of color, queer medical student, it's just so exhausting. Like, why would you want to subject that to yourself? But I feel like collective change can happen, even if it's just a little by little. But I feel like we can't feed into this idea that no change is ever going to occur, because this is just how life is, you know? And it's really like inspiring to see within my medical anthropology classes, to see all the really cool projects that are happening throughout the world. And I'll link those in our link tree, but to see like cool work being done to have more holistic practices. And I feel like insurance should accept more holistic practices or cover them as like an actual treatment, like art therapy, music therapy, having caregivers for people. Like, that should all be part of government programs, not just prescribing pills, which are like freaking like $300 a freaking pill when you try to buy them. And I am really happy to see like what Vicky said. Like, Vicky wanted more change in like the medical student system, essentially. And I am really happy to see, like, while I was looking to apply to medical schools, to see like current change actually happening right now. Like, they're switching from long, like typical interviews about yourself into short answer like question interviews that present case studies on medical ethics and medical anthropology and what you would do as a doctor and how you would evaluate the case. So I feel like that is the correct way to go, like actually trying to create solutions in real time to these policies that wouldn't have to take like 10 years. Like, there are really easy short-term changes that can happen right now. Yeah. And that is all we have for today. Thank you so much for listening, y'all. I know it's a pretty lengthy discussion, but I think we literally covered like all 3 years of medical anthropology into like one episode. So I hope y'all learned a lot and from our experiences, and I hope you can reflect on your experiences with your own health as well. That's what we want y'all to take from your podcast. And we might potentially like do another episode, but we will see. But we will keep y'all updated. But thank you so much for listening, and we hope y'all had a wonderful time with us these past few weeks. We had a wonderful time talking to y'all, and I couldn't ask for a better like group of people to discuss this with every week. It's been such a pleasure, and it's just so wonderful. Like, I am so proud of what we've done. So thank you everybody for listening, and we will see y'all next time.